All right. Looks like folks are still coming in, but we'll go ahead and get started. Thank you for joining CIVHC's Colorado All-Payer Claims Database Research Showcase today. We are very excited. This is the very first time we've done this, but we've gotten questions throughout the years, and all the time we answer the question, like, how is the APCD being used? What kind of results is the research that is going on? What are we seeing? What opportunities do we have to improve healthcare? Which is the whole point of the APCD, is how do we improve healthcare? How are we addressing affordability? How are we addressing equity? How are we addressing access and quality of care? So all of those things are being done with the data on a daily basis, and we are proud to work with the folks that are on the phone, and so many of you who are probably participating with us on this call today. But our presenters today, we're very excited to actually talk about how the APCD is being used in research and initiatives to do wonderful things for Colorado. So next slide, please. My name is Carrie Frank, and I'm the Vice President of Communication and Marketing here at CIVHC, and I am going to be your host today. Our agenda is to talk just really briefly about CIVHC and talk about what the APCD is, in case you're joining us and not familiar with the Colorado All-Payer Claims Database. We have 5 research and initiative presentations today. We will have time after each of our presentations to do some Q&A, and I'll talk about that here in a second. We'll talk about additional resources and data that's available and ways to partner with us. Next slide, please. So housekeeping, all your lines are muted, but we can talk to you through the chat box. During the presentations that you will see today, they're all pre-recorded, so feel free to chat your questions during the actual presentation. So if you are like me, you can't remember your question, go ahead and type it in. Our presenters may answer it right then on the spot, but then we will also have 5 minutes after each presentation to ask questions in a live manner so that you can chat that in, and the presenter can come off mute and actually answer your question live. We will be linking this recording. We're gonna be recording this whole thing and linking it to our event resources page at civhc.org. So everything that you see today will be available after the fact. Before we get into the meat of our presentation, we want to know more about all of you. So we have a quick poll. If you could go ahead and pop in there and say who you are. I know we have folks from within Colorado, folks across the nation. We would just love to kind of understand who's with us today. I know we have a lot of other state APCDs. I see that coming in, some payers, some consumers, some employers. Let's see, give it a few more minutes. So other researchers and state agencies. Great. Thank you. I think we can share the results just so everybody can see who's on the phone with us today. Spencer, are you able to share with folks?
It says I am.
Okay, perfect. Yes, you are. Sorry. So great. Thank you guys for letting us know who's here. We're really excited to have you. And if you could go to the next slide, I will just quickly go over a little bit about CIVHC. I'm not going to talk a lot about us right now because Darcy Holladay is with CIVHC, and she is actually going to talk a little bit more about our mission and what's in the APCD. But for those of you who are unfamiliar with CIVHC, we're here to equip partners and communities in Colorado and across the nation with resources, services, and data to improve health and healthcare. And our vision is that everyone has the opportunity to be healthy and has access to equitable, affordable, high-quality healthcare. We are a nonprofit. We pride ourselves on being independent and objective and service-oriented. Next slide. We serve what we call change agents, and those of you on the phone and those presenters are all in that category. It's any individual, community, or organization that's working to lower costs, improve care, and make Colorado healthy. So that's clinicians, hospitals, employers, all the list of folks that you saw in our poll, researchers, health plans, government, nonprofit, all focused on improving the lives of consumers here in Colorado. Next slide. So how we serve is we offer public CO APCD data, which I will talk about at the very end of our presentation. That is, there's a lot of information that we put out with the APCD data that helps folks identify opportunities for improvement in their community or in their organization. Those are often interactive data dashboards. We also have Excel files, all sorts of things that we provide publicly across a variety of different topics. And then we also offer non-public co-APCD data and evaluation services. And that's what you're going to hear about today. It's all been licensed data that we've provided to either researchers or state agencies and other folks who are looking for a specific project need or program evaluation services that we offer to measure the impact of folks' work in the community. Next slide. So today we're so excited to have some amazing presentations, lots of great research and initiatives that are going on. We are highlighting 5 here today. I'm not going to introduce every single person at this moment because I'm going to do that right before their presentation comes up, but this is just a glimpse at who you are going to hear from today. And first up, not because she's with Civic, but we love her, Darcy Holladay Ford, but because we have the opportunity to give you a little bit more background on the APCD. I'm going to let Darcy go first today, and we're going to look at her results of her research project on the effects of COVID-19 on end-of-life costs. So excited to hear from Darcy. And as I mentioned, if you would like to ask questions during the presentation, feel free to go ahead and chat that out to either everyone or the hosts and the panelists individually.
Good afternoon, everyone. I'm Darcy Holladay Ford, the Director of Research here at Civic. Today, I'm going to discuss the effects of COVID-19 on healthcare costs at the end of life in Colorado during 2020 and 2021. Just a little bit of background on Civic. Civic is an independent nonprofit providing unbiased data and resources to improve health outcomes across Colorado. As the administrator of the Colorado All-Payer Claims Database, we have and maintain a database of over 1 billion medical, pharmacy, and dental claims from over 49 commercial insurers, Medicaid, Medicare, fee-for-service, and Advantage, covering more than 74% of Colorado's insured population. However, the Colorado APCD does not include claims from ERISA covered, about 50% of those self-insured plans, TRICARE, Indian Health Services, or uninsured individuals. A definition of end of life. End of life care refers to the support and medical care given surrounding death, often spanning days, weeks, or months before death as individuals manage chronic illnesses. Civic has focused on end of life care since 2019. Our goal is to guide discussions on serious illness and advanced care planning. Today, we're presenting a cost comparison between COVID, cause of death, and non-COVID during the years of 2020 and 2021 for the end of life care. But on the background, previous studies have found disparities in end of life care. For instance, care intensity and access to hospice services varies by insurance type, according to Yang and et al. 2020. The pandemic has exacerbated these racial disparities in care, making findings especially relevant today. From 2021, as well as the pandemic's place of death among Medicaid and commercially insured individuals with cancer is also observed during COVID-19. So our study examines healthcare costs for Coloradans who passed during the COVID-19 pandemic. Again, through either cause of death of COVID or not the cause of death of COVID during 2020 and 2021. We looked at three things. How do demographics impact costs? How did costs for COVID-19 related deaths differ by payer type? And how did dual eligibility for Medicare and Medicaid affect these costs? We conducted a respective analysis of medical and pharmacy claims from the CIVHC APCD for individuals who died in 2020 and 2021. We excluded traumatic deaths and anyone that had fewer than 6 months of insurance eligibility. Our final study cohort was 51,559 distinct Coloradans APCD members who died in 2020 and 2021. We calculated cost on a per member per month basis to standardize comparisons. We then stratified the data by key demographics such as age, race, insurance type, and dual eligibility to identify patterns in care. A large portion of our population, about 59%, was over 75 years old. 65% were non-Hispanic whites, which aligns with Colorado's demographics, but only represents the insured population. And our study cohort, 11.9% of individuals died from COVID-19 in 2020 and 2021. Percentage of deaths due to COVID rose slightly from 11.5% in 2020 to 12.3% in 2021, with a total of 66,110 deaths overall during these periods. Looking at COVID-19 deaths by race and ethnicity, disparities became evident. Non-Hispanic whites make up the largest proportion of deaths. However, minority groups, particularly Black and Hispanic populations, experienced higher relative mortality rates, reflecting broader inequities in healthcare access and outcomes during the pandemic. COVID-19 disproportionately affected older populations in our study in 2020, especially. Most deaths occurred for those over 75, reflecting the vulnerability of this age group. However, we also saw an increase in percentages of deaths among younger age groups between 2020 and 2021, likely due to factors such as delayed vaccine access and shifting patterns in the spread of virus, as well as employment. Healthcare costs calculated per member per month basis in 2020 were generally higher for members dying of COVID when compared to other causes of death. This can be seen across all payer types, with commercial plans seeing the highest costs. In 2021, these costs increased further across all payers, reflecting the ongoing financial burden of the pandemic. Commercial insurance remained the most expensive, while Medicaid and Medicare also saw significant rises in per member per month costs. When we break down COVID-19 related deaths by payer type, we see distinct patterns. Commercial plans have fewer deaths overall, but contributed to the highest per member per month cost. In contrast, Medicaid and Medicare saw more deaths, but the cost per member were generally lower. These differences highlight the varying financial impacts of the different payer systems during the pandemic. Dual eligible individuals who were enrolled in both Medicare and Medicaid saw a sharp drop in the COVID-19 deaths from 46.6% in 2020 to 25.1% in 2021. While the vaccine rollout played a major role in the decline, increasing Medicaid enrollment during the pandemic may also have contributed by providing broader access to healthcare and resources for vulnerable populations. Commercial plans typically had shorter coverage periods, averaging between 2 and 4 months, while Medicaid and Medicare had longer coverage, averaging 9 to 11 months, indicating that individuals with public insurance had more consistent healthcare access, leading to their deaths. Commercial plans were only were only used as a high-cost supplemental treatment. And even with 2 to 4 months averaging, the costs were exponentially higher. There's several important limitations to our study. First, COVID-19 deaths have been classified differently across jurisdictions, leading to inconsistencies in the data. We use death records to identify cause of death, and the primary cause of death of COVID-19 is not always indicated. Second, the APCD only includes the insured populations, which limits our ability to cross generalizability across the uninsured as well as other states. And we also know that race and ethnicity data are reported by the payers and are not always reflective of individual self-identity and are oftentimes not reported. COVID-19 increased end-of-life costs across all payers, with commercial plans hit the hardest. Disparities in care remain, especially for vulnerable groups. More resources are needed for end-of-life care and future pandemics to reduce inequities and financial strain across all age groups, ethnic and racial categories. Here are a few of our references. You can keep those handy, as well as our contact information. Thank you so much for your attention. We'd like to open the floor to any questions and you have any feedback. Thanks so much. If you have any questions or follow-up, please outreach us. You can reach this abstract here, as well as my contact information and information about CIVHC.
Fantastic. Thank you so much, Darcy. I think that we do have, as I mentioned, we'll be able to take some questions after each presentation. So feel free to put any of your questions that you might have in the chat, and Darcy is here live to answer any of those questions that you may have. Darcy, as we're waiting for folks to come on, I wonder if you could let people know what other end-of-life research that is going on at CIVHC, because we've been doing a lot, and this was just one piece of what we've looked into so far.
Yeah, thanks so much, Carrie. We definitely, at end of life and older adults has been a focus of our internal research across CIVHC and has been for many years. We did this short cost analysis, which we typically don't do cost analysis for end of life, just to understand what that looked like from COVID versus non-COVID, and presented this at ARM research at a conference last year. We also have another more descriptive analysis around end-of-life care and inequities across race and ethnicities when it comes to not only that last year of life, but also advanced care planning. That publication was accepted for peer review at the American Journal of Hospice and Palliative Care and should be posted here in the next month, the 45 days. We also have a large portfolio of other research agenda kind of around end of life that we're currently looking for funding for to be able to conduct. Looking more into social determinants of health, we saw some really big disparities around urban versus rural, as well as some where people are located and what kind of care they have, as well as that access to really looking at more acute care. So ICU 30-day admissions versus outpatient and access to hospice care. So variety of different things in the works. And we also have another offshoot of a hospice analysis that we're currently going to present for poster review at ARM again this year.
Awesome. Thank you. And as you were discussing all of that, we did get a few questions in the chat box. So I will read some of those off. The first one's from Darren asking, was there any attempt to select cohorts across lines of business matched by age or clinical complexity? There should be some Medicare members that are similar in age to the commercial book, for example.
We did not in this analysis because it was a short and breakdown of just kind of what it looked like across COVID. Our other publication we used the Johns Hopkins RUB analysis or RUB score to be able to match individuals over their complexity of care to see what was the chances of somebody, say, being in the ICU based on their complexity, based on race, ethnicity, age groups, as well as the urban and rural, and advanced care planning, how did that impact? So we did that with that analysis, and we typically do that for much of our research. Look, how complete was the death data in the APCD? So we didn't use the APCD death data, we used death records. And so we transferred APCD claims, individual identifiers to CDPHE. We're able to match death records of individuals for those years. And then we got that list of individuals what were confirmed dead from the death record and then matched them to their claims. And we're able to look back in time as well as forward in time.
Awesome. And then there's another question. What percentage of older deaths had DNR or anything else that would limit care pathways?
So we did not do we don't have access to DNRs. We did in our other publication, like I said, looked at advanced care planning. And what we were surprised to see was that there was about, of our individuals that died between 2018 and 2021, about 33% of those individuals had advanced care planning in place, which is higher than national average. So it seemed like it did have an impact in their access to ICU, 30-day admission, and some of those acute care that individuals would, and that advanced care planning was more prevalent among those really sick people, as you would imagine. And that advanced care planning was much more prevalent in COVID years, because I think there was concerns about not being able to advocate for your care during that. So we saw a big uptick during COVID years.
Great, thank you. And then lastly, a question around policy implications. Are there any specific policy implications of this work? Sounds like continuous Medicaid coverage might take some heat off of the commercial sector.
We have, and I appreciate that comment, and I agree. We have been using COVID years with continuous enrollment to be able to understand different subsets of the population impact on that. One of which was the dually eligible for older adults as well as children, and what continuous coverage looked like for those 3 years that people were not unenrolled based on a variety of factors. And have additional analysis around that. So I do think there's definitely policy implications, and a lot of our partners that we are partnering with on these analysis and Medicaid Unwind are interested in being able to advocate for continuous coverage for a larger proportion of the state population.
Wonderful. Thank you so much. And thank you for the questions. Just because we're going to be moving on from Darcy's presentation doesn't mean we can't still ask questions. So please, if you have questions as we go to the next presenters, please feel free to continue to put those questions into the chat. But we are going to move on. Next up, we have Alyna Chien from Boston Children's Hospital. We're very excited to have her here with us today. Her research project looked at insurance gaps at ages 19 and 26 by childhood onset condition severity. So we're going to go ahead and play her presentation. And again, please feel free to post your questions in the chat box as we're going through, and we'll do another Q&A at the end.
Thanks for having me here today to share our research brief that just came out earlier this year. I'm going to talk about insurance gaps that occur for young adults at age 19 and age 26, using the Colorado all-payer claims data set from 2014 to 2018. I'm representing my team that is listed here, and also would like to acknowledge our funder, which is the Nationals, NICHD, and R1. Thank you. Our team has no financial relationships to disclose or conflicts of interest to resolve. To get started, I just want to share or point out that every year in the United States, 9 million young adults must qualify or re-qualify for health insurance. By law, these age eligibility cutoffs occur at age 19 for those who were prior Medicaid recipients and at age 26 for those who are dependents on parental commercial insurance. Although there is a rich literature around insurance gaps, it doesn't always focus on young adults. And certainly few, if any, have been able to examine how insurance gap patterns among young adults with different types of childhood onset conditions fare throughout the process. By childhood onset conditions, I'm referring to young adults who may have a chronic condition like asthma or attention deficit hyperactivity disorder, or they might have something that's a little bit more severe, which is a complex medical condition such as cystic fibrosis, sickle cell disease, or they may have a condition that is even more severe and lifelong, and that is a disabling health condition such as cerebral palsy or deafness. So the objective of this particular research brief was to simply characterize insurance gap patterns for young adults by 4 mutually exclusive clinical severity groups. Our methods included identifying over 1.2 million unique 10 to 29-year-olds within Colorado's all-payer claims database, also known as the APCD. We focused on the 5 years between 2014 and 2018, so following the Affordable Care Act and preceding the COVID-19 pandemic. A key feature of the Colorado APCD that we relied on was to be able to follow unique enrollees across health plans and time, so that we did not count health insurance switches as gaps necessarily. We based the insurance source on the first observed month of insurance. We focused in more on insurance gaps that last at least 3 months or longer and required them to be preceded and followed by at least 1 month of insurance. This means that we are providing a conservative estimate of insurance gaps and also focused on those that may have more obvious clinical ramifications. We identified our clinical severity groups using 3 validated claims-based algorithms. The first was the Pediatric Medical Complexity algorithm, also known as PMCA, the Children with Disabilities algorithm, also known as CWDA or SWIDA, and the Diagnosis to Impairments algorithms, DITA or DITA. Here is the beginning of our results. 52% of our study population was insured by Medicaid only in their first observed month of insurance. 47% of our study population was insured by a commercial health plan in the first observed month of their insurance. Since we were focused on age-specific health insurance eligibility laws, we excluded people who had more than one insurance source. That would be 1% of the study population, which had both Medicaid and commercial insurers, so we're dual in that respect, and also the 0.001% of young adults who have any Medicare insurance. Let me walk you through how this slide illustrates that the percent of young adults with an insurance gap peaks at ages 19 and 26. On the x-axis, we have age demarcated in years, but it is actually being measured by each age month between 11 and 28. And then on the y-axis, we have the percent of each age month with it that have an insurance gap that lasts at least 3 months or longer. In blue represents prior Medicaid recipients, and you can see that prior to the age 19, the percent with an insurance gap is around 3%. But that rises very precipitously just ahead of age 19 and then reaches a peak during the first 6 months of turning 19 and then drifts slowly downwards thereafter, but never really returns to baseline rates. Somewhat similarly, for those with prior commercial insurance, prior to the age of 26, we see that the percent with insurance gaps lasting 3 months or longer is more around 5% up until age 25, at which time there is also an increase up to a peak of 8.7, which occurs within 6 months of turning age 26. It also looks like it's declining, but it also does not reach baseline rates within 2 years. This slide is very similar to the prior slide, except for now it illustrates how insurance gap patterns differ by clinical severity groups. Medicaid is still blue and on the left, and commercial is still red and on the right. The deeper the color, the more disabling the health conditions are. And we have 4 mutually exclusive clinical severity groups. Dark colors are disabling, medium dark are complex, medium are chronic, and light means that there is no disabling, complex, or chronic condition for this young adult, for this set of young adults. On the left-hand side of the slide, you can see that prior Medicaid recipients with disabling health conditions have the lowest percent of insurance gaps, and those without any disabling, complex, or chronic conditions have the highest. On the right, among the previously commercially insured, we also see a pattern that is similar to the previous ones, except for now, those with disabling health conditions have the highest percent with insurance gap, and those without any disabling, complex, or chronic conditions have the lowest. This is the same information, except for now we have taken those with disabling health conditions and stratified them by the type of impairment that they have. Physical, magenta, sensory, orange, developmental or behavioral, green, intellectual, blue, or psychiatric in yellow. And the take home here is that it does not matter that much what your reason for having a disabling health condition as a young adult, but the patterns are pretty much overlapping, except for maybe the group that was previously commercially insured with a developmental or behavioral reason for having a disabling health condition. This is another view on young adults with disabling health conditions, looking at the number of impairments that they might have. And here we see a little more diversity in terms of whether or not you only have one reason for or impairment type for having a disabling health conditions, or 4 or 5. These numbers get very small, especially for the commercially insured group, which is why we can only provide information about commercially insured young adults with disabilities that only have one or two impairment types. In summary, this research brief illustrates that insurance gap patterns differ by insurance source, but each insurance source has a peak at their corresponding age-specific health insurance eligibility cutoff. Insurance gap patterns across clinical severity groups have different, similar shapes, but different levels. And our next steps will be to use regression discontinuity design to examine the relationship between turning age 19 among Medicaid recipients and the receipt of recommended care, chronic medication use, and use of emergency or inpatient services. Thank you. I'm open for questions now or anytime. Feel free to email me.
Thank you so much, Alyna. Important research to understand the impact of going on and off insurance for those age groups. Thank you so much for your important work. I have Amanda has raised her hand. Hold on. As we're going through questions, I think there's a question that is directed just in general, not directly to you yet, Alyna, but as we're answering that, please feel free to put in questions for Alyna's research into the chat box. I have a question from Kathy about our other states using this data at the level of Colorado, and I'm assuming using APCD data similar like this in other states for research purposes. Not every state has an APCD, so that is first and foremost an issue. So not every state has a resource like this. And then not every state has the ability to provide the data to researchers externally. So every state is a little bit different in how they're structured. Some states actually have the APCD within the state agency and have very specific ways they can use it, and they don't have a process to share it with researchers or other entities. So it just depends is the answer to your question. There are some other states that do have the ability and can provide data to other researchers and external entities. I'm going to plop actually in the APCD Council has a resource that I found that you can actually sort by different states and see what research projects have come out of those states at the APCD Council level. So
I would also add, just Carrie, one of the things that's really great about the Colorado one is this ability to track enrollees across plans and time, because that's another feature that not all APCDs have, or they can't do it at the monthly level. So like we could only do our study because we had the information so granularly at every single month of enrollment and also the birth month, so that we could know when somebody was turning a specific age. So it does matter, depending on the type of question you're trying to ask, like the detailed features of the APCD.
thank you for mentioning that. That's a really good point. Not only do some states not have one, they all look different. Every state is collecting the data in a different way and is able to provide it in different ways. So I think there are definitely some benefits to the way that we've been able to gather the information. And like you said, we have that member composite ID, so we can track people all the way back to 2012, no matter what kind of insurance they had, no matter where they went to provide or to get care. So I think that is a unique differentiator of our APCD, and I appreciate you bringing that up. We do have a question from a few folks, or a couple of questions have come in. Darren is asking, do you plan to look at which line of business the members landed in when they regained coverage after losing coverage, and what percentage went back into the same line of business?
That's a really good question. It was something that we did. This is the main purpose of the research program, is to understand the impact of having an insurance gap at that age 19 for Medicaid recipients. But the descriptive work we've done along the way to make sure that we understand what is happening has shown us that most people do land back into their original insurance source. I think if off the top of my head, it is like 85% who used to be on Medicaid are going back to Medicaid. And those who used to be on a commercial health plan are going back to a commercial health plan. There is some switching, but it's usually within the commercial, like different commercial plans, and not so much across Medicaid and commercial.
And also asking about, is there one limitation of the APCD is we can't mandate the self-insured employer plan. So
That's right. That's right. And then like our research program was more focused on Medicaid. So we were very glad to have all of the Medicaid recipients in Colorado. There is also some information about commercial health plans that, at least from a spending perspective, if you see one commercial plan, you kind of see them all. But it is really interesting. It would be better if we had like universal commercial health plan information, just so that we could be extra sure that we're not missing a gap or a switch.
And David Keller's asking, does your analysis suggest a need for changes in transition policy, particularly for CIVHCN, which I'm sure you know what that stands for.
Yeah, children or youth with special healthcare needs. Hi, David. Great question. I think it's a little early for me to be able to say anything about it, because right now we're doing that regression discontinuity design, which could show us that, hey, maybe young adults, even if they have a chronic, have a disabling health condition, might not be impacted by having a gap. But we're also very concerned that they might, because when a gap occurs, and our minimum was 3 months, the average went up to 8 months long. So that's quite a long time for someone who has a serious health condition to go without some kind of management. And I think we'll be presenting preliminary results at Academy Health in June, if you want to tune in there. But I can also come back to this showcase in another year, and my graduate student can.
We'll have you back on. That's right.
Yeah, that's great.
And then another question related to your next steps. Curious to hear thoughts on why the severity groups are flip-flop from Medicaid and commercial.
Yeah, so this one's a little bit tricky, and it has partly to do that we don't have the self-insured plans, so it is possible that that the patterns would be different if we had that 1/3 of data. The other thing is that we were trying to be very conservative about calling a gap. So we required that bookend and that duration. And there just might be more action happening in the 1 to 2 month gap, or like if someone leaves the data set, they actually are in a gap. Our paper has a supplement on it that actually addresses a lot of these questions. So if you really are kind of like a nerd like me, we did document it as these all came up, both on our research team and also by the wonderful reviewers. So they're in the supplement for the article.
That's great. Thank you. And then more of a comment that folks might land back where they were, where they started, but the costs of churning and gaps are enormous and unnecessary.
Yeah, I think the super unique feature, and it was completely because the CO APCD could do it, was that we can watch the exact month at which somebody turned age 19 or turned age 26, and we can use all their childhood data to figure out what kind of clinical background that that young adult might have. The surveys have not been able to do it at all. So I do think this piece is a little bit unique in just getting that like little corner of information about young adults specifically.
Awesome work. Well, thank you so much for being here and for sharing this. And we look forward to seeing the more results and more research that you conduct, and we really appreciate it.
Yeah.
So yes, again, Alyna is gonna, I think, be able to be here the whole time. So she'll be here if you think of other questions that you can direct to her. And you have her information too if you want to reach out at some point. So thanks again, Alyna. And I think we're gonna move on to our next presenter. We have Liza Creel with the University of Colorado Medicine Health healthcare policy research, and she is going to share her work researching equitable hearing care. So thank you, Liza, for being here. I look forward to your presentation.
Hi, my name is Liza Creel. Thank you so much for joining this presentation and for your interest in our project, Hearing Healthcare Equity in Colorado, which leverages and uses data from the Colorado All-Payer Claims Database to really understand hearing healthcare in our state. I want to acknowledge before anything a really wonderful team of collaborators that I have here at the University of Colorado Anschutz Medical Campus on this project. I am leading this work, but am very lucky to work with Bridget Mosley, who is a research services senior professional and data analyst within the Adult and Child Center for Outcomes Research and Delivery Science, or ACCORDS, here at CU Anschutz. Bridget is leading our data analysis of the data in the all-payer claims database. She has some experience working in this data set on other studies and has been really a wonderful partner in this work. We are also collaborating with Sarah Byers, who is also a data analyst within ACCORDS, who has quite a bit of experience working in hearing healthcare data, including newborn hearing screening data. And is helping us think through the approach we are taking, the models we are applying, that sort of thing. Finally, I will mention Elise Mention, who is a research services senior professional here in my division, the Division of Healthcare Policy and Research, who is really leading the research coordination and management part of our work. Finally, I want to acknowledge the generous support of Cochlear Americas, who supported this project, and the resources that were made available for us to purchase the Colorado APCD through their small grants program. So our goal in this project is to examine disparities in hearing healthcare and related services in Colorado. And we specifically want to document variations in use and access to services based on an individual, community, and system characteristics. We have three research aims. The first is really to examine utilization of hearing healthcare and related services across all payer types and adjusting for individual level characteristics, including comorbidities and medical complexities that may be related to hearing loss, and also prior service utilization. So we have a utilization aim there in aim 1. Our second aim really focuses on cost. We want to estimate costs to beneficiaries and also to payers associated with two key hearing healthcare related interventions, including cochlear implants and hearing aids. And this is important because of benefit design related to cochlear implants, which is a surgical procedure, and then also to hearing aids, which are historically not necessarily covered by insurers or payers, and can mean that when they are covered, there is a financial obligation on behalf of the beneficiary that may be really important to consider as we think about access to these sorts of services. We also want to measure disparities in access to these hearing healthcare services, what those are driven by, whether that's geography or provider availability, etc. I want to mention before moving on really quickly that our focus really is across the lifespan. So we are very interested in hearing healthcare of infants, all of whom, most of whom, are screened for hearing loss at birth. We are interested in hearing loss among children because we do know that some hearing loss in the pediatric period is acquired. And then we are interested in hearing loss among adults, and particularly older adults, where we know the prevalence of hearing loss is rather high. I want to just mention why we are doing this as researchers, of course, which we just sort of talked about, but also why this matters for Colorado, why this database, the Colorado All-Payer Claims Database, is really useful. So a lot of the work that has been previously done in hearing healthcare has used center-specific data. So it focuses just on patients who are getting care in a particular center. There's also quite a bit of national survey data that take weighted population samples and look at, for example, prevalence of hearing loss. This, we believe, is the first use of an all-payer claims data to look at these research questions. And we think that has real implications for improving health equity in the state by looking at variations in access to care, thinking through coverage limitations that may impact access to care among particular payer types, and really helping us understand where we might have the opportunity to improve access to hearing healthcare, which is very important for both children and for adults. Hearing loss is actually pretty common, particularly among adults, and lack of access is a major contributor to inequities. Part of this is driven by historical stigma on hearing healthcare interventions, but also access to specialty providers who provide hearing healthcare, and cost-related concerns such as out-of-pocket payment for hearing aids, for example. We think there's a lot of policy relevance in this work and the ability to really inform stakeholders about existing disparities in hearing healthcare, and how those vary across our state, and that this can inform benefit design, it can inform public policy, and it can inform clinical practice regarding the delivery of hearing healthcare services. So as I mentioned, most hearing health studies are center-specific or based on weighted population survey samples, and Haynes is the best example of this. We are thrilled to use the Colorado APCD because it facilitates analysis across multiple payers. It has a longitudinal perspective, and it's really it helps us focus on measuring disparities in receipt of hearing healthcare services. We, of course, acknowledge the limitations of this, including that those who are entirely self-pay for services or for specific interventions would not be represented in this data. That is a real limitation on our hearing aid analysis. And that, of course, claims are dependent on coverage for specific interventions. And we do know that that varies pretty extensively across different types of providers. Different types of payers, excuse me. So our study sample includes individuals with one or more hearing loss diagnoses between the years of 2012 and 2023. We received these data last May, and are working through a lot of descriptive statistics right now, and focused on really further defining our analytics. But we are really excited to have that span of data to help us really understand the trajectory of hearing healthcare for individuals in Colorado. We do include individuals without a hearing loss diagnosis, but evidence of a hearing healthcare service or intervention, because we know that diagnosis may have come prior to 2012 or prior to, for example, arriving in Colorado. The two specific interventions we are looking at are cochlear implantation and hearing aids. We are looking at all ages, as I mentioned, and all payer types focused on commercial, Medicaid, Medicare fee-for-service, and Medicare Advantage. Most of our analyses that I'm going to present descriptively do focus on the years 2015 to 2022, just because the samples are a little bit smaller in the earlier years, potentially not representing the full population. And we just want to make sure that we have the most reliable and valid data to comprehensively describe who is in Colorado with hearing health related needs that may be better served. We are analyzing pediatric populations separately from adults, mainly because identification in the pediatric population is quite different because of screening in the newborn period and also school-based screening. The needs may be different in those phases of life, if you will, as well. So our first kind of analysis has really just been to look at population level prevalence. So you can note here, these are sort of prevalence over time by age group, that we have an increasing prevalence. This may mean that people more people are being diagnosed or that more people are getting hearing related healthcare or support within the healthcare delivery system over time. We do see a dip in 2020, which is pretty aligned with other reductions in healthcare delivery during that time. But overall, increasing prevalence, particularly among older adults. The blue line with the arrow pointing there is sort of overall prevalence. You can see some slight increases, maybe 2 to 3% over that time. We see much bigger increases in the older adult population. And then in the pediatric population, we do actually see the highest prevalence in those under 19 with lower prevalence rates and sort of the decade of 20-year-olds and 30-year-olds, which is very, very consistent with the literature. I do want to talk a little bit about who we're seeing in our study sample. So we see the majority of people in the sample have a diagnosis of hearing loss, but no evidence of intervention. About 94%, we see a diagnosis. We do not see any evidence of cochlear implantation or hearing aid. But about 6% are getting one, the other, or both. This is also pretty consistent with the literature. As I mentioned, we are doing lots of descriptive work, some of which I've just shared with you, and are really framing out our more advanced modeling, statistical models that we are employing. We are modeling utilization of cochlear implants and hearing aids that will adjust for payer, for geography, for patient level demographics, and for provider availability. And to do that, we are linking in publicly available data from the Area Health Resource File and the Colorado Health Systems Directory, which is provider level data that we have requested. That request is pending. Again, we will be describing disparities in access and use of services over time for both the pediatric and adult populations. One of the things we are looking at is exploring the use of early intervention services as a related service for children who have who are deaf or hard of hearing. And then again, understanding the cost of hearing healthcare, as that has many implications for both coverage limitations and also public policy. I want to thank you very much for your time and for joining today. I'm happy to follow up with anyone who wants more information about our work. My email is available here, and I look forward to connecting. Thank you.
Wonderful. Thank you so much, Liza. Awesome work. This is near and dear to my heart. I just had a friend of mine just found out his baby, who's just 10 months, is losing her hearing quite rapidly. So great work to see how we can make sure that folks are getting access to the care that they need. Really important stuff. I welcome folks to ask questions again in the chat box. Liza is here with us, ready to answer any questions that you may have on her important research. So we'll wait
Carrie,
here.
While we're waiting, one thing I realized I didn't say in there, especially when I was talking about policy implications and what we think this means. You know, in my work, I collaborate a lot with providers in this space, a lot of otolaryngologists and head and neck surgeons who are looking at this in all sorts of spaces. And one of those spaces is a group of professionals looking at health equity and hearing healthcare, and it's called the Hearing Health Collaborative. And that is a space where we intend to really disseminate this work to people all over the country who are really interested in this. So it's just another dissemination strategy we hope to use.
Yeah, that's fantastic. Awesome. Darren has a question for you. Did you look at place of service? Was there any evidence of increased at-home testing rates during the pandemic? Could that explain the increase in prevalence for claims-based analysis?
That's a really, really good, Darren, you asked the best questions, I just want to say.
I agree.
So thank you so much for being here. Yeah, so we will be looking at place of service. I'm not sure if at-home testing is in there. I have not thought about that, and I have not heard about sort of an increasing rate of at-home testing during the pandemic. And mostly what we heard is that there was nowhere to go, particularly in the newborn space as babies were born and failed a newborn hearing screen. I think that might explain part of the increase in prevalence. I think the main reason we see an increasing prevalence is not because of a true population level increase, but rather that there are more resources for healthcare. There's somewhat less stigma around hearing related healthcare and interventions. There's more training in that space. I think it's a very complex issue, but certainly the claims-based aspect of our analysis biases that a little bit. Benefit design is probably our biggest issue here because there is just a ton of variation in what is covered in commercial plans, what is covered by Medicare, and what is covered by Medicaid. So for example, we know cochlear implants are covered by Medicaid in Colorado for children, but not for adults. And that I think is one of our bigger pieces of contribution or pieces of sort of evidence that we can lend to the literature around some of that. Is around benefit design, particularly in a time where we're seeing a lot of policy change around hearing loss in older adults, access to over-the-counter hearing aids now, which obviously we will not observe in this data set. There's just a lot going on in this space. Thank you for the question.
And then it looks like Darren also is asking, or just stating MA plans, Medicare Advantage plans have purchased lots of home health providers since the pandemic, CVS, Signify, etc.
Yeah, that's a really good point. I also had not thought about, but we would be able to look at it in terms of place of service if those screens were happening there. Thank you for that. It's a really good suggestion.
That's great. Thank you so much, Liza. I think we unintentionally put this slide up, but if anybody has any other questions for Liza, please let us know. I do want to make sure that we have enough time to get to our next couple presentations as well. But thank you again, Liza, for being here, and we look forward to more results as you continue this research. Next up, we are going to shift gears from something that's not really true research like we've been talking about in the same sense, but in a great initiative that's happening with the Colorado Department of Public Health and Environment. We have Steve Holloway here to talk about using claims data to provide revolutionary access to care and reduce health disparities with the work that they're doing. So thank you, Steve, for being here. We look forward to your presentation.
Hi, my name is Steve Holloway, and I'm Director of the Primary Care Office. Under statute, our office is charged with 3 primary functions. The first is the assessment of health professional workforce needs throughout Colorado. The second is to under clinicians into areas of underservice. Our research interest in the all-payer claims database is with regard to primary care claims analysis. A problem that we address is understanding how access to care is different based on geography throughout the state. Traditionally, we have applied a federal methodology that has been in place since 1977, which tends to prefer service areas that are constructed based upon municipal boundaries, such as county lines. In the absence of other kinds of analytical information, counties might sometimes, at least on its surface, seem like an effective approach to creating service areas. On the other hand, I think few of us have ever considered a county boundary when determining where we and our families would receive care. I'm going to share a map with you to explain what I mean. This map was created using all 2021 primary care claims in the state of Colorado. Our objective here was to better understand how people's choices for primary care at the individual level color a service area map that represents something closer to how people actually acquire care as opposed to simply relying upon county boundaries. The origin destination model is fairly simple in its construction. We look at the origin of the patient, that is where they reside, and the destination of care, that is where they receive primary health services. When creating this duplet over hundreds of millions of claims, we see patterns emerge in the data that indicates a service area. To illustrate, I'll draw your attention to the Four Corners area. In Montezuma County, if you are familiar with that county, you'll know that the town of Cortez is roughly in the center. It is the largest community in Montezuma County. And as such, it's the logical place for people to acquire primary health services. What you'll notice, however, is that the color of Montezuma County is shared with Dolores County and Western San Miguel County. What this indicates to us is that the preponderance of people who live in Dolores County and Western San Miguel County also elect to receive their primary health services in the town of Cortez. This is important because traditional models might have split off Dolores and San Miguel County from Montezuma County, which isn't actually a reality that we observe in the data. Furthermore, we might have made the mistake of putting San Miguel County into a single service area. Now, this perhaps makes some sense if we are unaware of some of the characteristics of that community, but it makes less sense when we come to appreciate that the eastern part of San Miguel County, Telluride, is culturally, economically, and socially quite different from Western San Miguel County, which is much more likely to be agricultural. Furthermore, it wouldn't make a whole lot of sense for the majority of people in Western San Miguel County to transit east up into the San Juan Mountains to receive primary health services, but instead elect to go on the north-south highway into Cortez to receive their care. As somebody at the state who is charged with resource allocation, we reveal more important information about these communities by evaluating the claims so that when we are determining which communities could benefit most from limited public resources, we consider Western San Miguel, Dolores, and Montezuma together as a single service area. There are other parts of the state where counties are indeed reasonable service areas, like that you see in Custer, Huerfano, and Los Animas County in South Central Colorado. But most other parts of the state, the picture is much more nuanced. Another example of that nuance occurs in Crowley, Otero, and Bent County. Based upon the primary care claims data, we know that La Junta is the center of care for those three communities. But if you live in Bent, Otero, or Crowley, more likely than not, you are choosing La Junta for your primary health services needs. But if you look closely, you'll notice that the northwest corner of Otero County is actually shaded purple, similar to southern Pueblo County. What that indicates to us is that if you live in the town of Haxton, you are more likely to select Pueblo as your primary care provider than La Junta. Again, this gives us important nuance when we're making decisions about access to care resource allocations for that part of the state. When we remove the county boundary layer, we can see the counties are much less prominent in the way that people acquire primary care. Now, you may be asking, is there more utility in this mapping process than simply allowing us to determine where Colorado Health Service Corps providers could best improve access to care in Colorado? The answer is a resounding yes. Because we build these service areas up from census tracts, it gives us essential demographic information at the community level that allows us to effectively create a social determinants of primary health score for each of the service areas that you see here. In other words, we can look at communities' characteristics based on poverty, income, insurance status, unemployment status, number of minor children per household, and make predictions about both the demand for primary health services and the likely barriers experienced by families in each of those service areas that are related to more social characteristics. Those service areas that have the highest index of social determinants needs is another example of ways that we can more effectively target resources to those communities that would benefit from our resources most. Also, because this is a claims analysis, we can evaluate ambulatory care sensitive conditions by service area. If you are familiar with ambulatory care sensitive conditions, You know that those are the kinds of claims that tend to show up with greater frequency in emergency departments within communities that have higher barriers to primary care access. Things like poorly managed type 2 diabetes. By scoring each individual service area according to its ambulatory care sensitive conditions, we can again see with greater detail which communities are experiencing the highest barriers to primary care and be able to specifically invest almost down to the address in communities that would benefit most from those added resources. Together with our health professional shortage area analysis, we will see with greater resolution the needs of communities. Another attribute of this map is that it is currently all claims and all primary care clinicians. The next step in analysis is to look at Medicaid enrolled clinicians and Medicaid eligible populations. We would anticipate that this map will change somewhat because people with public insurance have more constrained access to primary care services in their communities. That will again inform decisions we make at the state about how to determine where best to assign primary care access building resources in the state. This map gives us even greater detail into service areas in our most dense part of Colorado. As you can see, the Denver metro area is many service areas in a sort of mosaic. What you don't see is organization by county line. For example, we can see that South and Eastern Denver is more similar to Aurora in terms of a service area pattern. The west side of Denver itself is its own service area pattern. If you are familiar with the demographics of that part of the city, you'll know that some of our lower income neighborhoods are in that area. And those neighborhoods tend to be more ethnically diverse. You can also see in that hot pink there, areas of greater affluence in Denver, and again, an organization of primary care access that is more associated with higher income communities and insured people. As you can see, this analysis reveals a level of nuance that has never before been possible. In combination with income data, social determinants data, ambulatory care sensitive conditions, claims level analysis, and workforce capacity, we have new potential to determine exactly which parts of the state would most benefit from resources intended to improve access to care and reduce health inequality. We are excited about the analytical potential of this work. We know that it will better inform our choices for whom to support in improving access to care for underserved communities in Colorado. We are also eager to share this research with partner organizations that have a like mission and endeavor to reduce health inequity in Colorado. I look forward to your questions, your comments, and your feedback. Thank you.
Thank you so much, Steve. Appreciate all of that great work, especially all that you do for rural communities. Steve and I go way back, and when I was at the Rural Health Center in the States, I know that you guys have focused on so much in terms of providing access to care in rural communities. So thank you for all you do. Question on whether policymakers have access to this resource.
We're not currently publishing this map to the web. Certainly any elected officials in the state that wished to be briefed on this could contact our policy office and we can arrange to make that available. I am hoping that over the next 6 months, we'll have some of this work in publication, and we'll be able to get additional information out to the broader research community as well as policymaker community.
Fabulous. Question around looking at other years, since care patterns in 2021 are probably impacted by the pandemic situation.
Yeah, so we're aware of that impact, and in fact, part of what we hope to discern is sort of longitudinal change over time. So we are in the process of requesting 22 and 23 data. It is likely that our analysis will improve with even more data, believe it or not, even though we're at 500 million rows. We are probably not going to aggregate between 21 and 22, but we may aggregate between 22 and 23. Also related, we are looking at perinatal health access, pregnancy-related care, and expanding our behavioral health access. And so those are things that are also on, hopefully, the near-term horizon.
Wonderful. And Sophia, Steve is with Colorado Department of Public Health and Environment. Another question, how did you determine assigned PCP? They're from San Miguel County and have a lot of issues with assignment of PCP. Patients that we take care of are not necessarily always assigned to us from the insurance point of view, and the opposite.
So we're aware of attribution challenges. There's lots of different ways to approach attribution. We're aware of that as well. We make no claim to one being better than the other, but our attribution model is simply in the claim itself. Can we associate the individual person to a specific NPI? All of this data is managed in the Colorado Health Systems Directory, which was mentioned previously with Dr. Creel. It is an underlying data set that allows us to do some of that analysis. What we are not attempting to do is say, for example, when we subdivide this claims data between private payers and public payers, to necessarily use the assigned insurance attribution. That is something that we probably could do if there were a specific use case kind of among our network, and people wanted to approach analysis from that perspective. At this point, we are simply going to let the claims tell us which patient belongs with which clinician.
Great. And then another question on mobile integration health. Would be helpful in improving access to care?
It certainly would be. And in fact, many regions of the state are so minimally served by existing clinical workforce. And because the populations are so sparse, it probably is the wrong policy solution to suggest building another clinic and trying to populate that clinic. Mobile services are a really essential way to deliver care to very remote communities that are sparsely populated. This is certainly a geography-based model. As we move into more telehealth care delivery, particularly in the behavioral health setting, it's going to complicate our analysis, and we're aware of those things. We're kind of interested in the research community what some others' ideas might be to try and understand that component of care delivery. And in some respects, it might be an opportunity to really promote certain non-physical modalities of care delivery in those communities where it is most obvious in the data that that's the right policy strategy.
Great. Thank you, Steve. In the interest of time, I want to make sure that we do have enough time to get to our last presentation. If you don't mind, Steve, answering some of those other questions that have come through, and we really appreciate you being here and all the work that you're doing for our state. Thank you. Thank you. And yeah, let's go ahead and get to our last presentation. Last but not least, Dr. Brosi, Deena Brosi is here with the University of Colorado Division of Transplant Surgery, and we'll be talking about connecting upstream healthcare systems to the Organ Transplant Center.
Brosi, and I'm a research scientist at the Center for Outcomes Research and Policy at the Anschutz Medical Campus. And I'm going to talk about how our center plans to use the Colorado All-Payer Claims database to connect upstream healthcare systems to the organ transplant system. So in the US, much of the organ transplantation research comes from the Scientific Registry of Transplant Recipients. The SRTR is a comprehensive national data registry on waitlisted candidates, living and deceased donors, organ transplant recipients, and post-organ transplant outcomes. Recently, there has been some criticism around using the SRTR population to answer questions around disparities in organ transplantation. And when we look at defining transplant populations, those that are placed on the wait list and eventually receive an organ transplant represent potentially a very small proportion of all patients that may benefit from organ transplantation, including patients that are referred and evaluated but not placed on the wait list, or patients with chronic disease and end-stage organ failure. And if disparities exist in accessing the organ transplant waitlist, which they almost undoubtedly do, then our national SRTR registry does not capture the true denominator of patients who need organ transplants, and then may be biasing estimates when looking at disparities in transplant outcomes. So using the Colorado all-payer claims database, we believe that we can get access to this pre-transplant waitlist population in Colorado and more accurately represent disparities in transplant. So with CIVHC's help, we filtered the Colorado all-payer claims database using ICD-10 diagnoses and procedure codes for organ failure and organ transplantation. We selected patients falling between 2016 and 2023 and asked for information such as insurance type, insurance payment, pharmacy data. We also requested that we were able to link the Colorado all-payer claims database to CIVHC so that we could conduct survival analysis to mortality among our organ failure and organ transplant populations, and then geolocation to get access to unique information on social determinants of health, such as built environment or distressed community indices. After CIVHC delivered the data, it included 650,000 unique patients who had received an ICD-10 diagnosis code or procedure code for organ failure and organ transplant, over 175 million procedure claims observations. It had over 594 million diagnoses claim observations and over 124 million pharmacy claims observations. Some preliminary results when looking at the distribution of organ failure among Colorado residents, a majority fall into the category of lung failure, while second to that is multiple organ failure. A small proportion of Colorado patients with organ failure have kidney failure, although they do have a higher average number of ICD-10 diagnoses. So during our study period, kidney failure patients had more average diagnoses over the period compared to heart, lung, and liver. And that is interesting because when looking at organ transplants, kidney transplants represent a majority of organ transplant recipients in Colorado, followed by liver and then heart and lung. When looking at demographics across organ failure type, these look similar to national estimates, with a larger proportion of people with organ failure being greater than 64 years old, although multiple organ failure patients have a higher proportion being greater than 64 years old compared to other organ failure categories. When looking at gender, for some of the categories, there are more males with kidney failure and heart failure compared to females, but relatively similar distributions. This is not the case when looking at organ transplant. So for age, there are fewer proportions of greater than 64-year-olds across heart, kidney, liver, and multiple compared to when looking at organ failure demographics. And even more striking is that the discrepancy between males and females is greater when looking at organ transplant than it was when looking at organ failure among Colorado residents, which may be highlighting an access to care or barriers issue in Colorado. Another thing we were able to look at is the patient out-of-pocket medical costs and payer medical costs among those that had received a transplant. These graphs right here show estimated annual costs from a fixed effects analysis before and after a patient received a transplant. And when looking at the patient out-of-pocket costs, you see after the transplant, a significant reduction in annual out-of-pocket costs for liver transplant recipients and kidney transplant recipients, the heart and liver patient out-of-pocket costs were not significantly different following heart and lung transplant. The payer medical cost graph shows some high costs among heart transplant right before transplantation, and then a dip off for every category, but especially for heart transplant. The payer medical costs supports previous work that's been done on cost-effective analysis for transplantation, showing that payers pay less following transplantation for the patient, but the patient out-of-pocket medical cost graph is a unique analysis that was only able to be done using the Colorado All-Payer Claims database. So next steps will be to supplement missing variables for some of the factors that were included in the Colorado All-Payer Claims data. We asked for race because we believe that is important when assessing disparities. And there is a relatively high proportion of unknown and missing across all organ failure types. There is also a high proportion of unknown and missing race across all transplant types. Other next steps, because we have so enjoyed the relationship with CIVHC, and we are very pleased with the quality and quantity of the Colorado All-Payer Claims data, we have submitted other grants for research questions that require that Colorado All-Payer Claims database granularity in detail in Colorado. I think specifically we are looking at semaglutide or brand name Ozempic use among patients with kidney failure in Colorado, and we might be able to get that using the Colorado All-Payer Claims database pharmaceutical claims. And then we also plan on linking our current Colorado All-Payer Claims database to our UC Health Transplant Center data to then bridge that information of organ failure with referral and evaluation, which our transplant center should have, to then wait list and transplant outcomes. Thank you so much, and I appreciate the opportunity to present and work with CIVHC and receive the Colorado All-Payer Claims data.
Thank you so much, Dr. Brosi. We appreciate you using it, and we love working with you too. And thank you for your important research as well. I know we have only a couple minutes, but I do want to open it up for questions on our last presentation here. And thank you all for sticking with us over the last hour and a half. I know I've learned so much. We do have a couple questions coming in. I think you mentioned social determinants of health. If you did, can you talk a bit more about the source of the data you plan to use? Will that be based on Z codes, census data, etc.?
You're talking about with supplementing the Colorado All-Payer Claims data?
I think so. I think,
Okay.
like, how are you bringing in some of those other SDOH factors?
Well, one thing we were thinking about doing is RAND actually has a unique, it's called BIGS. I don't know what it stands for, but essentially it takes the geolocation of an individual for the missing race variables and their surname, and then it creates a likely race category for it. So that was one thing, that was what I was talking about with supplementing the missing race data, because having such high proportions of missing race in the Colorado All-Payer Claims database would create problems when looking at disparities, especially if it's disparities based on race and ethnicity. So we're going to supplement that. There's also data from the Economic Innovation Group that looks at individual's residence and kind of creates a score based on the average income in the area, how many people rent in the area, other things like that, to create a distress score based on the place that they live in. And we can apply that to a zip code level or an address level, and it kind of creates more of a measure of built environment, availability to resources that, you know, maybe much more farther upstream of organ failure, but then will, give us answers in accessing healthcare systems and then accessing organ transplantation. So yeah, there's a lot of available resources out there to connect all of these data with, especially if you have something like geolocation or zip code, you can merge all of these data sources pretty easily.
That's great. Thank you. And a question around, was this limited only to Colorado patients, or were all patients who were evaluated by the transplant center, including from other states, included?
So our center does have information on other recipients outside of the state. Colorado All Payer Claims Database only has access to Colorado residents. But if we, not with the merge with our transplant center, but if we wanted to, we could look at individuals in Colorado that access care outside of the state. So that might be something interesting to look at, but yeah, we wouldn't be able to merge this data and look at patients that were treated in our center outside of the state, which we treat a lot of, New Mexico patients, but we wouldn't have that transplant wait list or organ failure identifications for them.
Great. Well, thank you so much. I know we're a minute past, and I apologize that we didn't have as much time for questions for you. But we would love for you guys to reach out to any of our presenters. As we mentioned, they're happy to take any additional questions, and these slides will be available. It has everybody's information, all of the email contacts, or if you want to contact us directly, you can contact me at cfrank@civic.org. or info@civic.org. We'd be happy to help. If you're interested in getting access to data, we would love to help you, or any of our other services that we offer. Would love to have those conversations with you. And thank you so much to our presenters and for everyone who participated in the call today. We really appreciate it, and we look forward to another showcase in the near future. Have a great afternoon, everyone.